we go. Okay, and we are live. Okay, welcome everyone. So good afternoon. Thank you for joining our September general meeting of the CSRA Parkinson support group. I wanted to take a moment first before I introduce our speakers to introduce myself. My name is Logan Banks. I'm the president of the board for the support group. My contact information is listed on the back page of our monthly newsletter and on our website. So please feel free to reach out to me with any questions or concerns. Before our speakers get into their presentation, I wanted to ask Martha Ann Tudor to kind of bring us up to speed on what is going on in our local community.
So thank you so much.
And watch it. I got it with you.
Thank you, Logan. What a great way to bring this Tuesday to a close by spending this time with you all. I have had the honor of meeting and working with most of you. My name is Martha Ann Tudor, and I'm coordinator of the Parkinson Foundation Center of Excellence at the Medical College of Georgia at Augusta University, one of 33 Parkinson Foundation Centers of Excellence in the United States and one of 47 around the world. One of the many things that we do at our center is outreach. Free, community-based educational outreach. And we have some things going on in the near future I wanted to share with you briefly. Our programs are always listed in the CSRA Parkinson Support Group newsletter with links to register. While they're free, pre-registration is required. And this newsletter, as you know, can be sent to you every month at no charge, either in your inbox as email or in your US mailbox. So this Friday, October 1st, is the last day to nominate someone for our Outstanding Parkinson Care Partner Awards. Among those nominated, we will pick 3 finalists, each to receive a $500 Amazon gift card, and to share with us, hopefully, some pearls of wisdom or lessons learned or suggestions learned so far in your care partner journey. The only requirement is that the person living with Parkinson's be a patient who receives care at the Medical College of Georgia at Augusta University. And otherwise, it doesn't matter where you live, just simply email me at mtudor@augusta.edu before 5 p.m. this Friday, October 1st. October 30th, on a Saturday, we have a virtual program about managing Parkinson's mid-stride. Dr. John Morgan, who is the medical director of our movement disorder program, Dr. Colin McLeod, a movement specialist in our program, and I will present this program from 10 a.m. to noon that Saturday. Drs. McLeod and Morgan will talk about motor and non-motor symptoms. And I'm going to talk about care partner strain and why it is that we call Parkinson's care partners the hidden patient. And then coming up, right after that, there are 2 programs that I'm excited about. One, I am honored to present alongside Dr. Travis Turner from the Medical University of South Carolina, Jessica Schurer at the University of North Carolina, Chapel Hill, and Dr. Jenna Renfro about isolation in Parkinson's, with a special look at how COVID-19 has impacted that the isolation in Parkinson's. It's some really great insightful information, as well as some self-help takeaways on how to combat some of the damaging effects of that isolation. I also am honored to join some Parkinson colleagues in Illinois for a virtual program on expectations and pressures that the holidays can bring to those living with Parkinson's disease. And then December the 11th, what we think will be, hope to be, our first in-person program in a while. Dr. Colin McLeod will speak in the Athens, Georgia area on a Saturday about DBS and surgical options for Parkinson's. We have some other great programming happen at the new year too in 2022. And one of the soonest will be February the 26th, when we do a substantial symposium in collaboration with the Parkinson's Foundation for the LGBTQ community living with Parkinson's, and some of the specific issues and challenges that impact individuals who are intersected in those two populations. So anything that you would like to see us do outreach on, that you feel like is something that needs to be addressed, is under addressed, I so welcome your feedback, as well as any suggestions, any participation. We can always have volunteer opportunities. So if you're interested, please email me at my email address. And I'm going to hand you off to our COE medical director, Dr. Julie Couric, who's just a phenomenal expert whom I am so honored to work with every day. And the outstanding palliative expert, Dr. Sandhya Seshadri at University of Rochester, joining us today from New York to talk about palliative care and the comprehensive program for which we are currently training at our COE and currently rolling out, and is a requirement for all COEs. So I'll let you all go. I'm really excited about this program. I know it's going to be wonderful.
All right, well, wonderful. So Sandhya, you're our featured star speaker today.
Oh, good
So
God.
I'm just gonna kind of briefly introduce the topic, and then I'll let you kind of take the stage and talk to folks. So thank you again for your time and meeting with all of us today. We really appreciate it. And thank you, Martha, for that wonderful introduction, all that great work you do. You can see how vivacious and energetic she is, keeping our program going and thriving. So I just wanted to start off with a quick question to kind of get everyone thinking, is when you go to see your neurologist or your movement disorder specialist, for yourself or your care partner or family member, what would be most important for you in seeing that physician or that care team?
Important thing when you go to the doctor, Dr. Morgan. What do you feel is the most important thing when you go to see Dr. Morgan?
I think for me, I'm looking for relief and some improvement. You know, you kind of hope against hope that something has come down the pike that you're not familiar with, and it's going to make things better. Even if it's incrementally, it's a hope that we cling to.
Absolutely, exactly. Relief and
Right.
hope, right?
Right. Yep.
Thank you, Connie. Anyone else?
Progress and
Progress. Great. So one of the big leaders in the field that we're working with is Dr. Benzie Kluger, who's also at the University of Rochester. And he's made that bold statement that the future of medicine is palliative care. And sometimes it's the basic things when we come full circle. The basics of medicine is to provide that relief, that comfort, that hope, and that relationship. Everyone thinks it's going to be robots and gene editing, but really it's palliative care. And before we go forward, I just want to dispel one big myth about what palliative care is not. Okay, as your physician, I will be giving you, especially as we roll out this program, Sandhya, we'll be telling you a prescription for palliative care. So the number one thing I want you to take away from this today is that when we are giving you that does not mean that we're giving up on you. A lot of people hear that and they think hospice, end of life, they can't do anything for me. And it's the exact opposite. What it means is that we want to now envelop you in an extra level of support, a kind of multimodal, holistic, multidisciplinary team. You know, they say it takes a village to raise a child. So I think it takes a village really to provide good quality of life for our Parkinson's patients And their families, their kind of ecosystem, right? No one lives in isolation. Like Martha was saying, it's the patient and also their partner thinking of their needs as well and how everything goes together. We know that there's tremor, we know there's non-motor like constipation, but there's also grief, adjusting to the process and talking about those things. These are some things we're already incorporating in our care, but across those 33 centers, like Martha was saying, and eventually, you know, nationwide, we hope to systematize and make it more standard of care. And the thing too is that, you know, there's an expression that Parkinson's patients don't die. They just stop coming to clinic. You know, where do they go? There's a certain point where you don't see your patients anymore and they either can't make it or they're in a nursing home. And what's happening to them? Who's taking care of their medications? More than 50% of patients with Parkinson's die in a hospital. If you ask someone today, do you want to die in a hospital or at home? Where would you want to be? Ask yourself where you would want to be. And you know, there's 3 things in life we can't avoid, right? They say, everyone, you can't avoid taxes, back pain, or death. You know, and in America, too often we treat death like an option. And you know, it's natural. It's going to happen to everyone, and we might as well talk about it and make sure that we're not just surviving, but living with dignity and dying in a way that we want to be, with dignity and with our family, and having those tough conversations earlier on. And having this layer, when we talk about palliative, we want to talk about care from the beginning to the end and giving that support through the journey. Especially as I give the diagnosis, I'm not thinking end of life, but that part of the palliative, the questions, what's going to happen next? What's my journey going to look like? And that's, I'm going to let Sandhya take over because I could go on. And I feel like in the interest of time, it's already 6:15. But if there's one thing I want to take away from it is that maybe instead of palliative care, we've talked about calling it supportive care, so that it doesn't have the same connotations, but we want you to know that this is something we want to roll out to improve the quality of life. I see on here some care partners I know, and I know how difficult it is, that strain. Like Martha was saying, that hidden patient, and you're this in this ecosystem, you're in it together, and we want to address that in a more kind of head-on way. So with that, I'll let you, Sandhya, take the stage, please. Thank you.
Sure. Thank you so much, Julie, and thank you, Martha and Logan, and most of all, also to Kathleen and Richard Reynolds, who really started this whole process for me when I met with both of them back in March. A lot of what Julie has already said is pretty much the sum and substance of what I'm going to be talking about. I am as much a learner in this as anybody else. So I'm going to shy away from the title of being an expert. I'm not. So I look forward to all of you asking me any questions, which if I can't answer, Julie or Martha Ann will be able to. With that, I want to share my screen with a few slides that I had put together for our conversation today. I'm going to really be talking to you about a project that we're working on here at the University of Rochester in collaboration with the Parkinson's Foundation, where we're calling it Implementing Team-Based Outpatient Palliative Care in the Parkinson's Foundation Centers of Excellence. And that's a lot of words, which I hope to get through in the next few minutes to explain to you what exactly we're doing out here. So these are some words which I find to be most beautiful and poignant, and I think all of you will appreciate it, is that one of our most cruel failures in how we treat the sick and the aged is the failure to recognize that for most people, their priorities go beyond just being safe and living longer. Everyone wants to be able to live the life that they want to live. And while we cannot avoid suffering, we can choose how to cope with it. How do we find meaning in it? And how do we move forward with a renewed purpose? So I first off want to acknowledge that our project has really been funded by the Patient-Centered Outcomes Research Institute. And PCORI is a part of the Affordable Care Act, and they were very kind and generous to give us the funds we need to be able to do this work. And so this is a broad overview of the people on our team. As Julie pointed out, Dr. Benzie Kluger is really the principal investigator and the brains behind all of this. And he's the moving force who every day reminds us on what's most important. And that, which he says is most important, which I echo, and I know all of you will appreciate, is that we need to start figuring out how to move the needle. How do we push care to be really putting care back in the words of healthcare? And so that's kind of where we are at. And in collaboration with the Parkinson's Foundation, Ronnie Todaro, Nicole Yarab, Megan Dini, Isabel Lena are all my colleagues there at the Parkinson's Foundation, and we work together every single day. So as I mentioned, our project team is Benzie Kluger. We have co-investigators here at the University of Rochester and at the University of Colorado, in addition to people at the foundation whom we work with closely, Eli Pollard and Diane Perrott too. And in Colorado, we have Dr. Jody Holtrop, who's an implementation scientist. So I'm going to turn these questions to you, like Jody started off, whether I know most of you are care partners of someone with Parkinson's, but at some level, all of us are patients. We've all been to doctors for a variety of reasons. And so I would like you to reflect on these questions. What matters to you most today? And given your health today in terms of your care, what are some of the things that you'd like to see happen? And what is something that you definitely don't want to happen? When you think of the future, what are the things that matter to you the most? And we're all going to get to a place someday, God forbid it will not be really bad, but if the health situation worsens, what do we want to make sure does happen? And what do we want to make sure that does not happen? And this is kind of the sum and substance of what we're talking about when we speak about palliative care. So what really matters ultimately to people living with serious illness, whether it's Parkinson's or it's cancer or it's any other type of serious illness, is most people want to spend time with their family. They want to know that their family is supported. And as Julie pointed out already, we all want to be treated with integrity and dignity and feel like we have some control and choices and how do we live a meaningful life. And if we have a serious illness, we kind of want to know what's ahead. What are some of the things that we want to deal with? And yes, there are symptom control things that we'd like to know, how to deal with pain, how to deal with depression, how to deal with fatigue or constipation, as in the case might be with people with Parkinson's disease. But also, we want to figure out what really matters to us is what are things that bring joy to our lives? What are the activities and the connections and the rituals that we go through that bring joy to our lives? And so I put this question back to you. When you hear the word palliative care, what does it mean to you? And I welcome you to unmute yourself. Tell me whatever you're thinking so we can make this a conversation.
End stage care is what I always thought of.
Sorry, what did you say? I missed it.
This is Gil. What palliative care means to me is a plan.
Yeah.
That we project ourselves beyond where we are, where we know we're going to end up, and that we have a measure of control for that through basically through knowledge and as you say, through a team-based approach.
I love what you just said, Gil.
To me, the word palliative is terrifying. I much prefer Dr. Keurig's idea of calling it supportive care.
Yep.
Palliative just has such a connotation to me of debilitation and, disabled and going down the tubes. Support sounds so much more hopeful.
And I'm with you, Connie. When I started this work with Dr. Kluger, I always associated palliative care also with end of life. And that's not uncommon. When we've been through the course of this project, we've talked to so many people, and I'll tell you that the jury is still out there. There are some people who feel that the word palliative care doesn't bother them, and there are others who are like, I will not go if it is called palliative care. And really, sorry, go ahead.
This is Marika. I also had a negative feeling towards the word palliative and associated it with end of life and doing the best you can with really bad situation where a lot was beyond your control and someone else was trying to give you the best that they could. So that word, I like the supportive care. It meant more like what you described for me.
I agree with that as well. You know, working in senior living for many years, it seems like the word, you know, hospice evolved into palliative care. And,
Right.
you know, I think that just, you know, realistically, especially for those with Parkinson's, it doesn't make sense because that's not what you're getting with this type of palliative care or supportive care. I really do like that message as well.
Sure. And there are a lot of people who think like you, Logan and Marika and Gail, that it does tend to have that, because I think palliative care kind of grew in the world of cancer. And so we've always associated it with end of life. But the word palliative really, sorry, somebody was saying something? I didn't mean to cut you off.
It's Martha Ann. I was going to have my 2 cents just add in there, and it's just totally with what you're saying. But, you know, as I mentioned, we are in the process of training. It's a comprehensive 2-year training program. But you're right. I mean, everyone who's talking about palliative being associated with end of life, that is traditionally, historically, I think the research shows palliative was usually something that was introduced and talked about maybe in the last 2 or 2.5 years of life usually. But one of the amazing things that I love about this program, one of the life affirming things about this program, is it starts at diagnosis.
Yep.
And it's not about, you know, let us know when you get in a hole and we'll try to dig you out, but these are prophylactic, preventative, and also let's help you with the most support to live your fullest, you know. So it's important to notice. And I hear what everybody's saying and what Dr. Kirk said too about maybe the term is not the best term, you know.
And you know, when you get down to actually implementing it at your center, I know Dr. Kluger is often mindful of saying, if the word palliative is going to prevent somebody from coming in through the door, I don't care what you call it. But just that, I just want to throw it out there that really when you go down to the root of the word palliative, it comes down to it meaning that blanket or that cover or that comfort. And palliative care is, as Steve Pantelat, who's a said, is really about living as well as you want for as long as you're able to. So as much as we associate it with dying, it really means that. And in the World Health Organization calls palliative care, you know, there's a whole slew of things they talk about with reference to defining what palliative care is.
When I saw,
sorry, go ahead, Marika.
When I saw the description of this whatever presentation today, I just was diagnosed within the last month with early stage Parkinson. So I thought at first, well, if this presentation is focusing on palliative care, I'm not there. I mean, it's not going to be relevant to my interest, which has to do what is my journey going to be like, and I'm at the beginning of it. And so palliative care, but then I read further and I thought, no, I think, you know, they have a different meaning in mind, but my first reaction was that it didn't apply to me.
Yep. And that's a common reaction, Marika. A lot of people have that reaction, and understandably so. And I did too when I first started this work. But what I love about the work is that we're looking at it as an approach to caring for people. And it really even, there's you know, some of our patients and care partners who have worked with Dr. Kluger have written very poignantly about it also. Their publications, one of them calls it dropping the bomb when you get the diagnosis.
Yeah.
It's like the bomb has been dropped on you. So now when the bomb is dropped on you, how many of us would not love for having a provider or a nurse or someone in that healthcare facility to take care of you so you don't just blow up inside on your own and implode because the bomb has been dropped? And that's really what we're talking about when we talk about palliative care. It's an approach to caring for someone with serious illness. And it definitely is not the same as hospice. It's not a death squad. It's not about giving up on people. It's not about doing nothing. And it's not only for people who come out with a medical degree in palliative care. That is, you have that whole specialty of palliative care physicians. It's not just for them, or it's not just for those who are imminently dying or who have cancer.
Yeah,
If you have to compare hospice with palliative care, hospice is for, hospice is end of life, and it is palliative care at the end of life. And it's for anyone who has a life expectancy of 6 months or less. But in palliative care, it's for anyone at any stage based on whatever it is that they need to help them manage and live the life that they wish to live.
One of the things that I wanted to say was we have had the palliative care nurse come for my husband, and they are very, very good at explaining a lot of what you're saying. This is not because you are fixing to die. This is another, I look at it as just, it's another hand that's helping me to help him. And I kind of feel like that what they do is they're very clear with all of what you've talked about for the caregiver and the patient to know that they're just another resource that can help both the patient if they have questions, or if the caregiver has questions. They see what progress they're making. They may see something that needs to be addressed, and maybe the person you're taking care of is a little bit more open with that nurse about something than they are even with the caregiver that's with them all the time. And another thing that I found very helpful is that she takes a portion of her time to just be supportive to the caregiver.
Yep.
Are there any questions that I have? Or so I guess for me, and I'm not the one with Parkinson's, it's my husband, but the palliative did not really bother him. But I think it was because she explained it just like you have, that it's just another resource. And if you get that off the table in the very beginning, we don't think you're fixing to die. We're not here for the last 6 months. And her visits have been very helpful to both of us.
I'm so glad you've had a positive experience with that. And that's part of what our hope is also with this work, is that no disease process, no serious illnesses ever belongs to just a part of a body or just to a patient. It is something that goes well beyond, and I mean, I don't need to say that to you. And that's why when Dr. Kluger speaks, he often says, the time is now to think about palliative care. It's not when we are all imminently at the end of life. And by that, it means that, especially for a disease like Parkinson's, I feel it's kind of incremental and chips away at people little by little every single day. So what may have been the comfort you needed at the beginning may not be the comfort you need a year later or 2 years later. So it's a process that needs to be revisited, and it needs to be revisited with the patient, the family, and the healthcare team that's working with them. And so in that case, I just wanted to also highlight that we know that for the palliative care issues that people with Parkinson's have, the non-motor symptoms are always more burdensome than the motor symptoms, as a lot of the research has shown. Demoralization and spiritual challenges exist. There's complex bereavement, there's prognostic issues. There are a lot of palliative care issues that weave so well with being able to provide the care that people with Parkinson's need and their families need. And the current models of care that we have, as much as they've become very good at addressing the motor symptoms, they're not quite there when it comes to addressing all the other host of things. There's poor recognition and management of non-motor symptoms. there's high rates of hospital and facility deaths. Like, Julie already alluded to that, and she said how 50% of people with Parkinson's die in hospitals, and who wants to die in a hospital? I mean, when my time comes, I want to be in my own home with all my loved people around me. And then there are institutional barriers. And given the healthcare system within the United States, these institutional barriers literally are there, they're state to state. There are variations in what's available and not available in terms of nursing homes. And then with Parkinson's, you also have the issue of young onset Parkinson's. We have a patient who is on our advisory council who got diagnosed at the age of 29. At 29, so she's looking at a potentially long life, or an entire life, where she has to constantly be thinking about what's next and what's next and what's next. So the current chronic care model really is, you have a patient and you have a caregiver. Either the patient is dealing with a neurologist on one side, the primary care physician on another side, and trying to find resources on their own, or the patient and caregiver together are trying to find resources on their own. So sometimes with this model of care, yeah, the motor symptoms handling are good. The non-motor symptom treatment is about fair, but we're very poor at addressing things like advanced care planning, caregiver support, psychosocial and spiritual needs, which is why we think that palliative care complements standard chronic care. We're focusing on the total pain of the illness. So this is not just the back pain or the physical pain, but it's the psychosocial pain, the spiritual pain, the practical challenges. How do we improve well-being? How do we affirm values? Because we don't want to just be thinking of what's happening at the end. We're all still living. So how do we live well, the way that we define living well to be? So Dr. Kluger often says in that context, everyone deserves a palliative approach. We deserve to be treated with skill and compassion. We deserve to have our emotional and spiritual concerns addressed. We need families to be supported. I can't tell you, I wish I had a penny for every time in our part of our work, we've talked to a patient or a care partner and said, do you talk to your doctor about your emotional or spiritual concerns? And they all come back with, why would I talk to my neurologist about my spiritual or emotional concerns? Why? I don't want to be wasting their time. And they're so concerned about wasting the movement disorder specialist time talking about these things when it fits well within the notion of primary palliative care. So this is one of the papers that Dr. Kluger and his colleagues published, where they did a full-fledged randomized control trial, and they found that it really improves outcomes for both the patient and the care partner when there's an integrated outpatient palliative care approach compared to the standard care. So our project really, as I said, has been funded by PCORI. It's a 3-year project. We're close to finishing year 1 in November. And we want to be able to take this approach, educate and train people, not just the physicians on what primary palliative care is, but everyone working at a center of excellence in the United States, and then hopefully beyond that to a lot of other places, on what does it mean to provide a team-based palliative care approach. And we want to look at how to create sustainment of this kind of approach so every single person and every family gets this approach, whether you a center chooses to call it palliative, or they want to call it supportive care, or they just want to call it care for PD. It really does not matter what words we use. It's the opportunity to be able to give people what they rightfully deserve and should be getting. So in our team-based approach, we're looking at a palliative care team that will not only manage complex medical systems, but will talk about spiritual well-being, talk about psychosocial issues, and help people with planning and preparing for the future. So for this, we're looking at primary palliative care as the foundation. We're looking to community and advocacy groups as being very essential. We're also partly looking at the cost, because when you think about healthcare systems, the questions of cost come in. And we're looking at how to integrate even specialist palliative care. And hopefully at some level, we'd be able to also push for policy changes and resources. So for the purposes of our project, we're saying there are 5 pillars of palliative care. There could be many more that come out over the course of the 2 years, but we really want to be able to have systematic screening and management of the non-motor symptoms, care partner assessment and support. I don't know how many times I've asked people talking to them during the course of our research study, have you as a care partner ever been asked how you're doing? And every time I get like either a shocked response or, well, that would be nice, wouldn't it? And so we want care partners' needs to be assessed and they need to be supported. We want support for psychosocial and spiritual issues. We'd love to see an annual advanced care planning, not because anyone is imminently dying, but because the one thing that we know for certain is we're all going to die. And so we need to be having those conversations on how do we want to die? Where do we want to die? What are some of the things that are important to us when we get to the end of life? And then when the time comes, when there really is, we're at that end of life, we want to be able to have a system where we're referring to a specialty palliative care or a hospice when it's appropriate. So we started this, like I said, in November. We're right now in phase 2, where there's an online education and training program that's going on for all the centers of excellence. And Julie and Martha Ann are very much involved with all that. We've got experts like Dr. Kluger, Dr. Miyazaki, and Dr. Vaughn who will be coaching and providing support to all the centers of excellence. And they will be working on trying to figure out how to build sustainment for these efforts. So I'm just going to end with that and leave it open to any questions you may have. Dame Cicely Saunders was one of the first people who started talking about palliative care. And I love her words because that really captures to me the essence of what this is. And that is that you matter because you are you. You matter to the end of your life. And we will do all we can, not only to help you die peacefully, but also to live until you die. And then John Kabat-Zinn, who said, extending the reach of our own heart lets us live in a world in ways that embody greater wisdom and compassion, loving kindness and equanimity, and ultimately the joy inherent in being alive. And Dr. Kluger often says when he meets with patients, I've watched him do this, where he says, I want you to know, I will never abandon you. I will never tell you that I have nothing more to offer you, because that's just not true. We may not have a cure for Parkinson's today, but there's always something that we can offer. And that may just well be that we all in the field of healthcare are there present and available and compassionate and kind to the people who are in this journey and are, struggling through it. So I'm going to stop my sharing of my slides. If you have questions, I'm happy to answer them. If you'd like to talk more about it, that would be fabulous too.
I just want to start off by saying something, Sadia. I got involved with the Parkinson's support group here, not because I have a family member with Parkinson's. Dick and Kathleen asked me to kind of help with some technology things. And as I heard everyone's story, I kind of learned if you're not near a center of excellence, which we are blessed enough to have here in the Augusta area, you truly get your diagnosis and then they say, okay, have a great day.
See you in 6 months.
And I mean, if you get a diagnosis of diabetes, you have here's the channel you take, cancer, here's the channel you take. And, I really got involved with this group because I saw how underserved not just Parkinson's, but movement disorders in general are. And I think that, it astonishes me that it's taken, this long, and bless you all for doing this work, because it's something that when you look at it, you think, this group of individuals, should have this, like you've said, from day one, from diagnosis. So, thank you for presenting. Everybody, please ask questions. I just had to say that because this is truly an amazing program.
Thank you so much for giving me the opportunity to share. Like I said, I'm just part of a much larger group of people who are doing this phenomenal work. And every single day, it is an honor for me to be able to interact with people who go through so much. And I can't tell you enough about the number of patients or care partners I have talked to who, in the midst of their deepest difficult times, tell me what a blessing it is and what blessings they live with every single day. And I'm just grateful for being able to be a part of this. So yes, please ask questions. Julie's also here. She's the expert in the field. And I'm happy to share what I know.
And I am not. I am learning from you, and it's a learning process. This is an evolution, and we're looking to shape it, in the next few years in the movement field and across countries, and make it more standardized and be a channel, Logan, like you were saying. And part of that will be getting input from the patients and their partners. It's about you. It's about what you need, what living well means to you. And we're here to serve you and work with you to achieve that. So we need your feedback and what matters to you. So
Hey, this is Gil. Can you hear me?
Yes,
Yes.
Gil.
Okay. I was with Benzie at the beginning of this march in Colorado.
In Colorado. Mhm.
And my name is on that original paper too.
Yes, I recognize it now.
And the team thing is so important here. And it's so difficult for a number of reasons. Number one, MDSs and neurologists in general don't like to be members of a team that they're not the captain of. And number two, the number of MDSs is going down relative to need. And so placing this priority the way you have is brilliant. But it also brings up a bunch of structural hurdles that we have here in terms of making it work. For example, I think at a local level, for this to work, there needs to be a Parkinson's center, okay? Where people who have gotten their diagnosis, who've gotten educated, who've gotten empowered, can then go to the Parkinson's Center and find the resources they need to implement their plan. So this is far-reaching, and it's going to take time, and it's going to take a lot of hard work, but is the right stuff. And Benzie's had it right from the start, and I'm sure glad that I was there at the beginning of the march.
I'll let Benzie know that you were also part of this group today. He'll be excited to hear that.
Tell him.
But you're absolutely right. There is so much work that we have to do. And as part of this project, every day, what is exciting for me is waking up every day to listen to all the different ideas. And one of the things we're looking forward to do down the road is to see if the same education that we're providing to people at the centers of excellence, if there's a version we can make for patients and care partners, because you can't just do this alone. We'd love to have patients and care partners also feel that they're not burdening their doctors by going and asking for help.
Mm-hmm.
And so that needs to happen. And so, I can only share with you what someone said to me once, that there is only one way to eat an elephant, and that's one bite at a time. We may never get to eat the whole elephant, but at least we can try little bit at a time.
May I ask how it is going to be worked? Because I'm wondering how, when you say you're training the people for the palliative care, who are you training? Nurses or the psychologists or the doctors, or who are we going to talk about when you say somebody who takes care of palliative care?
Thank you for asking. That's a great question. Yeah. So what we've done, Kathleen, is that we have created an education and training program for all the people at the centers of excellence. And what we've asked is that pretty much anyone, right from the person who is at the front desk checking in patients to the medical director of the team, should at the least do just that one first introduction to what palliative care is. We're asking that all the nurse practitioners and doctors, there are 10 different modules in the education course. We'd like for them to do all 10. But the reason we're saying the first module is one in which Benzie explains what neuropalliative care is, and pretty much in much more eloquently and powerfully than anything that I've shared with you today. And I think that becomes important because when we talk of a team-based approach, I really envision it being as something where even the person at the front desk who's checking you in or taking calls should be taking note of what neuropalliative care is. Because if someone calls in and is sounding distressed or feels like If they know that we have a program like this at the center, they can just, either go to the nurse or to Dr. Kurek or somebody and say, you know what, this person called in for this reason. I think they may need XYZ type of support, which is why we want all of us to be using the same language. And we're saying, if everyone can do this, that would be so wonderful. Does that answer your question, Kathleen?
And
Yes, but
Kathleen,
then what about, hello?
excuse
Well,
me.
what I'm,
I know that you come to our center, and I can just tell you too that at our center here at MCG at AU, everyone is completing the entire program.
Oh, wow.
The person answering the phone, the admin, she is doing that intro and first lesson, but everyone else, research staff, social work coordinator, nurse, our rehab, as far as our speech, physical therapy, occupational therapy, everyone is doing the entire program.
Thank you, Martha Ann.
How will I be introduced to it? In other words, when I go make an appointment with my movement disorder doctor, I see him and then I leave. I never have any idea of what other people I could see, or that. Do I make an appointment with a palliative person? Do I have to make another appointment, or what? How does that integrate it into the present program?
So Dr.
That is something, sorry.
Yeah, you go ahead.
No, I was just going to say that is something, Kathleen, that we're hoping it'll all get integrated in the course of time. We're just sharing this information with you. Every center will decide what their resources are and how best they can do this. So once the way I'm visualizing, and Julie and Martha can jump in if this is not quite the way that you're seeing it, is that once the team at the center has had an opportunity to take this education, then we're going to be working during the course of the next 2 years with the coaches. Will be guiding people like Julie and Martha Ann to develop projects that will make most sense for them. So certainly overnight, everything is not going to change. Whatever they feel they're going to be able to address right away. So for example, if they choose and I'm just using this as an example, at Augusta, that they're going to be focusing on making sure that systematically all non-motor symptoms are always addressed at every single visit. Then they're going to be working with the coaches to develop maybe templates that will go into their computer system. So every time a patient comes in, they are asked about all these other questions. So immediate effect for you in your next visit, I can't envisage how that's going to be, but hopefully you will see it over time. And then the second part of it is the education on the patient and care partner side also, right? So I don't want to promise a million things if the system is not yet ready for all those million things, but you will see changes over time, and that's exactly what we're hoping for.
When you say team approach, who is in my team? Who's the team that I'm going to be working with?
I love your question. So your team really is technically everyone at the center. So if Dr. Kurek or whoever is your physician feels that you need to be seeing a physical therapist, and I see Haley has commented that she as a physical therapist provides a lot of care. Haley will get an opportunity to see, not only learn from this entire course, but there are things like pain, which are very much a part of Parkinson's disease. And many people experience excruciating pain. And I can't tell you, I've had patients tell me, why would I talk about my pain with my doctor? And so as a physical therapist, understanding that pain, and I know many PTs work with patients who have pain, they will be able to do it. So for you specifically, your case, when you go to see your doctor, they will determine who are the other people. But as part of that team would also be the nurses. So if there's something that you bring up with them, they would be able to collaborate with other people in the center. I'm not sure if I'm answering your question.
Yes, I see what you're saying. So it's not right. It's not something that I'm going to see right now.
At the next visit, well, yeah, I mean, I think it might take a little, honestly, we've just at the beginning of it. So we're going to be meeting with Dr. Kurek and Martha Ann and others at their team in the Augusta Center over the next couple of months. And then when we meet with them, we'll know exactly where they are. They will talk to Dr. Kluger and others who are the coaches to start deciding what would be their goals for the next 1 year. And then with those
Nice.
goals, they'll start addressing each one of the 5 pillars that I mentioned. They'll start addressing those in a systematic manner. And it will happen, but it just may not happen next month.
I see. Because I just cannot imagine having somebody, the doctor to say, so how's your, how are you feeling about your ability to travel or anything like that? Because that's really pretty hard to explain, and also have them take time or take up their time for it.
And
know
you
what
were
I'm
one of the
saying?
people, Kathleen, who talked to me about the time and being very respectful about your doctor's time. And that's exactly where we want people to understand that you're not asking of something that is unreasonable to ask. There was one doctor we talked to at another center of excellence as part of our research data. And I really loved what he said. He said to me, he said, Sandhya, the buck stops with me. So if a patient calls me up and says, I'm going to have surgery tomorrow, what do you suggest? Should I do this or not? It may have nothing to do with Parkinson's, but I feel like rather than keep referring them out to a million specialists, I should be able to offer him the support that he needs and be able to give him the comfort that he needs.
Great, yeah, that'll be wonderful. Thank you very much.
Thank you.
Dr. Seshadri,
Yes.
I have a more generic question. So the palliative care approach seems generic enough that it could be applied to any disease. For example, I was diagnosed with Crohn's disease when I was 12 years old.
Mhm.
So that was the beginning of my diagnosis. And lots of diseases, chronic diseases that are out there, all over the place. So I guess, is there anything that could be learned with the model you're using from other examples that are being used for other diseases, or is Parkinson's really the first attempt at a broad approach at palliative care?
So that's what I would call a Benzie question. He knows the literature a lot better than I do. But what I will say is that, yes, it has been used in cancer a lot. We're starting with Parkinson's because we have such a wonderful collaboration with the Parkinson's Foundation. But every step of the way, I know Benzie often says when we meet with a center of excellence, he'll be like, if you've got colleagues who are working with patients with ALS, with multiple sclerosis, bring them on board. Let's share all the resources we have. Frequently at the back end, when we have conversations, he will tell me we should start expanding and figuring out how we can share this with our colleagues who are working with patients who are, say, in the deaf population who have illness. Why shouldn't there be a palliative approach pretty much for any illness? And so the pie in the sky dream is that that'll be available to all of us, no matter what we have. But for now, we're starting with Parkinson's. And I think it's also because Parkinson's has so many different symptoms that even patients half the time don't know that could be related to Parkinson's. Mm-hmm. And it's so complex that we want to be able to highlight and say that if this approach works here, it should work pretty much anywhere.
And Sandhya, already in the training I've been doing, with Benzie, he has addressed this, Dick, and he has said that historically, the only time you've seen palliative care begin at diagnosis is when you're dealing with childhood cancers. But as far as adults, it has been thought of as sort of an advanced stage thing, but it's different. This is different. And Benzie has said one thing that excites him so much is that he believes there's a really good chance that movement disorders, Parkinson's, will be what leads the rest of medicine.
Very good.
Thank you, Martha, and you've summed it up beautifully.
And so, but that's just, like you said, it's a good, Benzie loves these kinds of questions. So yeah, it is, but you're right. Dick, this is something, it's like, well, why isn't everybody doing it? It ought to be, because it's really all of us, as Sandhya has said.
Yeah, like I've got a brother who was diagnosed with type 2 diabetes, and he has suffered immeasurably as a result of that. If he had had more of this team approach, and I think team approaches in the medical business is more and more a part of the way things are being done generally. But he never had that team approach. And so he had to figure it out for himself, and he's made a lot of mistakes and everything else. And it would have been nice to have had something like this, to address his disease, which
Yeah.
is, I guess, the dream for the future. But for right now, I think it's wonderful that you picked Parkinson's to try this model.
Yeah, and I'm sure Julie will agree with this, that it's almost like medicine is coming full circle, right?
Yeah.
We started at one point in time, if you think about our grandparents, the local, town or village physician was your one-stop shop for everything. And he or she was the kind of person who knew everything that was going on in your family. He knew what little John was doing and why that was causing more stress to mom, and therefore how that was playing out. And he took care of, or he or she took care of everything. And then we started getting more and more specialized, and we started farming out different pieces of the body to different specialists. And now we're coming full circle to bring it all back and say, all the specialists, let's gather around, because, certainly one person can't do everything, but at the same time, why not use the distributed expertise that we have?
A word that hasn't been introduced yet is telemedicine.
Yes.
Because, for example, here in Middle Georgia, 23 counties of Middle Georgia, we have not one single practicing MDS, okay? And so to close the circle on the stuff we're talking about, we're going to need technology to extend the expertise of the MDSs. So it's another one of the things that we really have to pay attention to in terms of how we can use it to our advantage.
Yeah, you're absolutely right about that. And I think this COVID era, for all that it's done for us, I always say that Zoom is a blessing and a curse, because you live with Zoom meetings all day long, but at the same time, I mean, look at the access it's given us.
Yeah.
And so, as I said right in the beginning, when Benzie says we've got to at some point start moving into policy changing and figuring out those pieces of it and becoming stronger advocates for what all we need. I hear you. Telemedicine may well be leading the way in a lot of that.
Yeah, and to both your points, I think it's advocacy from you guys and from us in medicine for systemic changes and law changes and insurance changes to enable and support all these endeavors, because otherwise it's just pie in the sky. It has to be practical and it has to be supported. One of the things we're struggling right now is, as Sandhya was saying, the laws are different from state to state. So right now, when I'm trying to get hospice for a patient, I have to write, palliative, I have to write /hospice. Otherwise, insurance, it triggers, right? And it shouldn't be like that. And I have to explain, I know you're not dying. I don't think you're dying, etc. And with the telemedicine, Gil, like you were saying, it was immediately covered. Like Sandhya was saying, there's been many blessings, and what seemed would take years to overcome these barriers to get telemedicine covered suddenly disappeared. And now patients have gotten used to it and see the benefit of it. They don't want to let it go, but it's your voices, I think, that you'll have to advocate and fight for that. And there was just a few days ago, last week, there was the International Parkinson and Movement Disorder Congress that meets annually. It was supposed to be in Copenhagen, but of course it was virtual this year. And there was a lot of lectures about how to conduct interdisciplinary and palliative care through telemedicine. So it's a big area of research, and there's so many things that can be done just as well, nearly. I would say I wouldn't want to see a new patient via that, but continuing the care. And that's so much, when I was first thinking about it, I was like, how can PT evaluate a patient over a screen or swallow? But there's people are, they're ingenious and come up with all these clever ways, and we've been creative, and there's all these great kind of parallel measures that we can do. So I think that will be the future, and especially because there's so many specialists and teams, and we don't live in the same buildings, and it's hard for us to communicate. This allows us to maybe meet and discuss a case, talk about, different measures, and makes this a much more practical endeavor.
For care partners too, though, you know, Julie, to that point, I mean, talking to some of the people at the support, you know, at our support group, it's, you know, 2 doctor's appointments is their whole day. I mean, from getting the person that they're caring for
Yeah.
ready in the morning, in the car, you know, all the medicine packs that they need to take because they're going to be gone all day, and you got to hit those dosages at the right times. You
Yep.
know, I mean, telemedicine revolutionizes that, especially from a mental health standpoint for them. You know, why not via Zoom add that extra appointment in that's, you know, talking spiritually or, you know, just about how you're feeling.
Mm-hmm.
Easier to talk about something like that when you're not in front of a doctor's office. You know, when you're in the doctor's office, you feel like you're doing something just for the you have to have something concrete to talk about that makes the doctor's visit not wasted time, you know. So if you are talking about telemedicine and have a palliative conversation about palliative care with somebody more relaxed, even if it's on the Zoom, it's much easier to talk about things when you're relaxed instead of in the doctor's office and you got to get out quickly or something.
And actually, you're right. You're right, Kathleen. I've also heard from doctors in our part of our work when we were talking to them who said, it actually is nice. And I know Martha and you alluded to it also when you and I talked, that when you're talking with someone in their own home, it gives you so much more information on how best you can help rather than see them in your clinic. So, you know, especially I know physical therapists have been so creative where they're like, oh, I see that carpet. I can see where that fall can happen. And so definitely there are things to be said for telemedicine, and I hope we can all advocate to make that a reality for everyone.
One of our first, when we had our institution did not have telemedicine before COVID-19 descended upon us. So we all learned on the fly. And I think, at least for me, my thought was, well, we'll just see how good we'll, you know, offer the best we can under the circumstances. And I think I told you this before, Santia, but one of the very first patients that I talked with who told me how she loved telemedicine. And she said it was the first time I didn't cry myself all the way home after my appointment because she would look around clinic and see people who were more advanced than she is and feel like, well, what's the use? And she found that very profoundly discouraging. And of course, in the People's Outcome Project, we know that taken together, depression and anxiety are the #1 predictor in the quality of health for those living with Parkinson's and their care partners. So it's very important. And you talking about and informing our care through, you know, telemedicine. I know one, like I hear pharmacy, because you can show the person your pill system, for example. There's no more, or I forgot to bring it, you know, I take a white pill. You can show them, this is my system, this is how I'm taking my meds, how I'm, you know, what can we do better so that I'm not forgetting and things. So there's a lot of strengths.
Sure.
I also want to tell you, I love that quote about they help you live until you die.
Dame Cicely Saunders, she had it right many years ago.
Dr. Keurig, one of the scary things about Parkinson's to me is the fear of getting dementia. Is that going to be addressed in this team approach? I'm absolutely scared to death of being that kind of a burden. You know, physically, if I still have my wits about me, I can handle it. But dementia is just terrifying.
Well, absolutely. And Sonia had alluded to that. You know, the things that are important to patients and that bring them joy is being with their family, and also making sure that they're not a burden to their family, that fear of being a burden to their family. Right. And that's the real psychosocial stress and grief. And that would be something that we'd want to address. And, you know, it's a grief that you're living through that may not actually happen. It's like Mark Twain said something along the lines of like, I lived through so many terrible things, only to find that they never happened, right? You know? So it's just the thought, like somebody once said with Parkinson's, like that patient who left the visit and went through the waiting room, they're doing okay, but it's that fear of like, what might happen next? And what is my journey gonna look like? And what is the roadmap? And that fear can be worse than any of these physical symptoms or other things going on. And that's where I think that kind of working with the therapist and the social worker and the chaplain, you know, because the physician can't be everything, right? This is a team. The physician can't be the social worker either, or the therapist, but together we can address all these things. And, you know, our job is to also kind of, I guess, be the beacon and coordinator in that one-stop shop. We noticed, like, you know, like I know on my part, if I notice some psychological distress or something going on, I'll be like, hey, Martha, you know, I'm worried about this patient, or the caregiver, and kind of throw the ball to her. And she takes that right up and is on that and calls them and gets in touch. And, you know, it's a teamwork kind of thing. But in terms of, you know, the dementia, that, you know, first of all, there's testing that can be done. And sometimes having some objective data is helpful, because sometimes you might, it's like we always think the worst of ourselves rather than other people, like this stain on your shirt. You think everyone sees it, but no one even notices. They're busy with everything, you know? And you might think that, you know, your dementia is worse. And then if you get anxious about it and then you get depressed, depression can present as pseudo dementia, and you can see how this spirals. So our goal is to kind of stop that spiral, talk with you, work it out. And, you know, whatever happens, we're on the journey with you together. Even worst case scenario, you get demented, we're here for you. We'll make sure that you're comfortable, that you'll be living the way you do, that you help to get you the support that you need. So no matter what, you feel prepared to face it.
Great.
And to
Thanks.
add to that, the other perspective also, which I love, is what Julie just mentioned. Just this afternoon, I was working with the chaplain on our team, and we were looking at the whole, you know, for caregivers. So when we're patients, we worry that we are burden to our caregivers. And there's so much that is said about caregiver burden, but when you think about caregivers, one of the things that I loved that one care partner said to me was, he said, you know, my wife is in such a hard place with her Parkinson's and all the other issues she has with it. I've been advised by people to bring in somebody who can physically take care of her so I get some respite. But I can only tell you this, I'm terrified of doing that because she's the love of my life. For someone else, it's a job. For me, she's everything. So the worry for the care partner is, am I doing enough of a good job in caring for the person that I, you know, that I have lived with and has meant so much to me? So we all carry different levels of that burden, you know. So it's not easy, but the idea is that with this approach, every one of us will get the support that we need. And no matter where you are in the stage or in the trajectory or in the journey, you have someone whom you can turn to.
That's what I don't understand. This is why I don't understand about the teamwork. Because if you say a teamwork, it's like a whole team, you're going to go visit a whole team at the same time, or you're going to make different approaches with different members of the team.
So
you're going to the doctor.
Yeah. So the idea, Kathleen, is that depending on each person's needs, the physician, like Julie said, she may not be able to address some of the emotional needs, but she's got Martha Ann on her team. So if someone presents with a situation that they need that help, then Martha Ann can pick up the ball and run with it. If there is something else that someone has, like they've got really bad a problem with constipation or with pain or something like that, the movement disorder specialist may work with you, but the idea is that the whole team will work together to coordinate that care so that you don't feel like you're running, or your spouse doesn't feel like they're constantly trying to manage everything and struggling with it. So that's the team part of it. And I wish I could give you something more concrete, but all I can say is just hang in there. It's coming.
Mhm.
Okay, that's good. That's very hopeful. Thank you.
You know, and Kathleen, like Sanjay was saying, this, we're introducing this to you to let you know that this is coming down the pike. We're just starting the training and talking about it. So like, we can talk at another time. What would you ideally like to see? I know in some centers like the Muhammad Ali Center in Arizona, it can be a one-stop shop. Kind of like we have an interdisciplinary clinic where people come to see us, and that same day they see a physical therapist, a speech therapist, a social worker, and try to provide that interdisciplinary care where it's centered around the patient. They stay in the room and we all come and see them. So in some centers, it may look like that, really, where you're there and you might get a check-in from everyone. In some other places, it might be where you see one person that day and we kind of like toss the ball to someone else, but make sure, whether it's through communication in the chart or templates, that we're hitting all those important things. So how it will practically roll out here, we can't really say right now at this time. And I think across different institutions, it will look different simply because they're built and set up differently. But I think the spirit and the guiding purpose and intention behind it in all these places will be to provide that extra layer and make sure that you have those different people that you can turn to depending what it is you're facing.
It's Gil. It's Gil. A thought. Let's not lose sight of how important it is to be proactive, be your advocate. We talked a lot about support. What we need, we need educated people with Parkinson's and people who are energized to look after their best interests. So you have to be aggressive with this son of a gun.
Yes.
Or it's going to get you.
Yeah. And
As a
Kathleen,
doctor said,
no, the one thing that struck me, Kathleen, when I talked to you first, and I shared this with Benzie also, is the kindness of thinking, I don't want to waste my doctor's time in talking about my emotions or my aches and pains. And why would I do that with my neurologist? And this is kind of the place where we want to share these ideas with you to say, it's never a waste of time. You're helping yourself. So, be assertive and ask for what you want. And that's where the part of the training also comes in, because sometimes all of us need to be reminded on how to have these conversations. How do I open up these conversations with patients who come in or with families that come in? And if I've opened it up, do I know that I have the resources to be able to fulfill what you need, right? I don't want to be promising more than I can do. So as Julie said, every center is going to be different. Some centers have amazing resources that they have access to. At others, they're just 2 or 3 people who are working out there, and they have to farm out to community resources. So hopefully it'll all come together at one point.
I guess a question, what Augusta's Center for Excellence look like? I'm just a new patient, and I've had my diagnosis through a really careful, I felt it was a very careful interaction with the diagnosing physician. What am I missing there? What should I be doing now to follow up on that first diagnosis that is helped by the Center for Excellence, that I'm really happy is here, but I haven't figured out how I can best take advantage of the fact that there is a Center for Excellence here.
Well, that's a great question. I'm going to jump in since I'm the coordinator, and I hopefully meet with, if not in person, then on the phone or through telemedicine with new patients. We do a psychosocial assessment, and I do a pretty robust introduction with the Parkinson Foundation resources, with things like our local support group, with support groups that you might be interested in. But the point is we are saying, and you're hearing sort of the theme, it's not a one size fits all. So we really do see everybody as unique, because as Dr. Kirk often will say, to know one person with Parkinson's is to know one person with Parkinson's. So every journey is different. It's one of the cautions I give when I take people over to the Parkinson Foundation website, which is a treasure trove, but to, hasten about perhaps not getting overwhelmed, because you're going to be seeing resources that you may never even need. You don't need to go be reading about swallowing. You may never deal with any swallowing issues, that type of thing. So I think, as Santia and Julie and some others have all said, we have we will have resources, and we will have people here to help meet whatever needs you are having today. And we will have those resources and people to help you with whatever may be coming, what big or little problem may be coming down the road. So,
And
yeah.
So it sounds like I have a responsibility, which makes sense to me, to communicate somehow what might identify my needs and communicate with someone at AU regarding those needs. And I'm not sure who that person is. Do I get back to the diagnosing doctor? Is there a nurse? Is there a communicating person that I should know that I don't know?
So I don't know if you're talking about needs like prescription needs, clinical needs.
No, I was
scheduling
thinking
needs.
about the needs caused by the symptoms.
Well, if we're talking about, so I would be my honor to work with you to say, what are your goals in your life? So for example, if you're like, I want to keep riding horses, I want to be able to spend time with my grandchildren, I want to be able to take this trip. We work together for how can we create a plan for you to help you continue to do the things that are important for you. What are your goals? What can we talk about? Psychosocial aspects. How can I help you create a support system? Do we need to help build one? Do you have relatives who would be interested in a support system? If it's things like that, then I would be the one. Is it things like that?
Excuse me, I'm shilling for my book, which is a wonderful
we do have
book
this
that tells
awesome
you really what you need
resource.
to know.
Yes, we
Counterpunch,
do.
Sticking Out with Parkinson's.
Yes.
It's a hell of a book.
It is great. It is great. Amazon today.
Thank you.
But please email me at mtutor@augusta.edu. Email me and we'll get you started.
Martha Ann is your one person who would be able to connect you with whatever you need. And I'm so glad, Marika, that your experience has been a positive one so far. And I think that's the whole thing, right? Whatever your needs are, if there's one thing you take away today, it is don't be shy about asking for what you want.
Absolutely.
Yes.
So go ahead and ask for what you want, and they'll figure out at your center as to who the best person is for you to get what you need.
And you don't just get one chance at that.
Right.
You can, exactly. you can think of something new tomorrow. You can have new needs tomorrow. It's just to know that the main message, I guess, that I would also echo with what Santia is saying is that you're not alone. You're not alone.
And your local support group too. I mean, if you're newly diagnosed, normally we do these meetings in person, and you connect with people like Martha Ann. Martha Ann and I are pretty much the last people in the room normally, because that's obviously what Martha Ann does. And then kind of what I'm here for is to connect you with people in our support group who may be facing, the same challenges or maybe experiencing the same things as you are. And everybody in the group loves when a new face shows up, because tell us your story. How can we help you? Well, let's go to lunch. We have this, that's what we're here for.
The monthly meeting, that support group meeting, I would find out about through.
So you can sign up for our newsletter, and then we do a whole kind of bio on each speaker, all the different exercise programs, different care partners luncheons.
Yeah, I know there's something I have to tune into. Thank you.
Well, clinical trials too, as far as the newsletter, then the newsletter is going to be a great resource of information if you're a patient at MCD.
Called in for the clinical trial for new people, newly diagnosed who have not yet taken med, because that's me. And so I'm have a call in, and the person's name is Farrow, Buff Farrow.
Yes, Buff is our research manager, but Marika, I'm just going to go ahead and say right now, I want to congratulate you because you're already doing it.
Yeah.
You're advocating
Like
for
you got
yourself.
here.
Yeah, you're here. I mean, you're advocating for yourself, you're showing up, you're equipping yourself with
I
information.
am determined.
Well, yes, and that will take you a long way. And you have support here. You're already forming a support system, you know, you're staying connected. So you're already doing it. You
Yeah.
already got started.
Dr. McLeod is the one who diagnosed me, so.
Yes, and he's great and very thorough.
Yeah, he is.
Yep, and so we have 3 movement disorder specialists, and so yes, all 3 are excellent, and you're in great hands.
Remember, as a center here, we're connected with physical therapists who are trained specifically in Parkinson's disease, because not all physical therapy is created equal.
Yeah.
Therapy for a stroke or an injury is very different from the needs of a Parkinson's patient, which is freezing, balance, moving the arm, all those kinds of things. Here you have access to those specialists for the physical therapy, the swallow, the GI. Our GI folks are very interested in Parkinson's and do a lot of research in constipation, and, having the local support group, the Rock Steady Boxing, our social worker, the therapist, psychiatry. I mean, there's just so much that's right here. So, but I would say number one, I would say 2 things are always the most important starting your journey. And as they're saying, I say Parkinson's, it's like a painting. There's so many layers, and you do, one visit at a time. But education, being an educated and empowered patient. Okay. Number 1. Number 2, exercise. It's the only thing that's been shown to slow down the disease, create more dopamine, make you feel better. It's free, it's done safely, has no side effects. So those be my biggest 2 takeaways. And do everything that you're doing. Show up. You got here today. You're in the support group. Stay connected. It's vitamin C, which is community. That's important too, right? And just like stay with a questioning mind and proactive, and
Hey, guys, it's Gil. I have got to eat supper. It's been delightful.
Okay.
Visiting with your support group. It's really, really active. And I look forward to seeing more of you, and I will be in your town soon. So thank you so much for having me.
Wonderful. Thank you for
Look forward to
stopping.
meeting you,
Thank
Gil.
Meeting you, Gil.
All right, bye.
Great to have you connected.
But Marika, you call me, I can throw more resources at you than too many. We have too many resources. We have so many.
Wonderful. That's
And
what
the good thing is, hopefully I will listen well and be able to come up with some things that meet you where you're at, with your, taking into account how you like to receive information, what your current situation is, and things like that. So
good.
I'm going to do a shameless plug too, Marika, for you. This Saturday is our People of Parkinson's Walk, the 22nd annual. So that would be kind of a great place. I don't know if you're up for that, to just casually meet members of the support group.
Yes.
It's at First Baptist Church. Registration starts at 9, walk starts at 10, and we have raffles and fun things like that. And real, something that I always want to point out that I think that we don't point out enough is, not one person sitting on the board or a member of the support group kind of organizing body is a paid individual. So every single, dime that's invested and raised through the walk is given back to research, to patients, to care partners. So that's a great place to start if you want a fun event.
Absolutely. Thank you for reminding me. I saw it on Facebook.
Good.
Well, if we're
Everybody.
all, does anybody have any other questions?
Thank y'all so
Everybody
much
appreciate
for doing
Hi,
that.
Barbara.
Love you.
Love you.
Thank you. Well, thank all three of you for, speaking. I think this has been an amazing evening. We're 30 minutes past, and I think it was every minute was worth it. And I hope that, we'll all get to meet in person, hopefully sometime soon. But, to your point about Zoom, I think it has really connected, so many of us. And I really have appreciated, personally, I've appreciated this evening. And it sounds like everybody else has as well. So thank you all.
Thank you
Thank
very
you.
much.
Thank you.
Thank you very much.
Thank you, everyone. Thank you for this opportunity, Logan.
Yeah.
Always happy to have you, Martha-Ann.
Thank you.
All right.
Great
Have a
night,
nice night,
everyone.
everyone.
Bye-bye.
Bye.
Bye, Dr. Suzashi.